Let your curiosity rise.
Matrix webcast,
Where the human spirit flies. Matrix webcast. Where the human spirit flies.
Hey, welcome to the Medbix webcast. This is Ramana Annam Raju. You see those two lights is not a alien. Is not coming from aliens. It is actually some window problem here. So I'm going to fix it. So don't be nervous about it. No alien is here. But so we will see what is going on with the new revelations about the UFOs and UAP, unidentified flying objects, unidentified aerial phenomena. Is interesting subject, and let us, that's going to be waking up for us. Now, um, let me introduce. This is a second one from this month of May. Let me introduce you my co-host, who drives a pickup truck, red pickup truck, and then drinks beer. Hey, that is a doctor of nursing practice, Susan Davis. Welcome, Doctor Susan Davis.
Yeah. What an introduction. My claim to fame. Thanks. Nice.
Yeah, that's good. So,
Ah,
how many people the red pickup truck and a beer on the hand? Yeah, I like that kind of woman. So, what is going on with you? It's a busy life.
always living my best life down here in South Florida. It's getting hot. Getting hot. We're hitting the 90s. We're in the middle of a drought. But it's cool. Summer's on its way. We're just getting ready for our normal steamy hot summer. And this time of year, half the world that comes down here leaves. So it's kind of nice.
Yeah. I lived in Florida briefly. Oh my God, Tampa area is not. It's not fun. Most of the times, the bugs bothered me all the times.
Oh,
I'm done. I
yeah.
was riding a horse up there for a while. I did it one time.
Well,
That
we
was not a,
We do
you
that on
know,
purpose. Right about this time of year, we let out all the bugs, we let out the mosquitoes and the no-see-ums and the snakes and the gators, and then we stir up a hurricane or two, and then we get, the streets are a little clearer for a couple months. It works out quite well down here.
I'm okay with the Golden Gate Bridge. I don't need all this. All city life, all the cement is okay with me. Okay. We have a very good guest, and she came second time. This is coming on second time to our podcast. Um, Dr. Mary Leung, she's a hematologist, a medical oncologist, and a physician coach at the Mount Sinai Healthcare System in New York. She is born in Hong Kong, just I came to know a minute ago. She grew up in Hong Kong. I had a very, Susan, I had a very interesting connection with Hong Kong, is that one of my first gave a person who gave me Vanderbilt genes manufacturer, Mr. Mujani, gave me a scholarship. So, but anyway, that's a long story from Hong Kong. Um, Beyond treating the cancer, she focuses on the deeply human side of the medicine. She helps patients and their families navigate the psychological and emotional realities of serious illness, terminal diagnosis, and grief. That is She also supports families and healthcare professionals through some of the most difficult moments in medicine. Welcome, Dr. Maryling. Welcome, Dr. Maryling. How are you? Thank you
Yeah,
for
thank you
coming to
so
the
much for
program.
having me.
Yeah. Thank you for joining us. Tell us a little bit about your background. I just filled a small, pieces of introduction I gave. If you can give us a little bit more introduction for you, if you can tell us a little bit background of yours. Yeah.
Yeah, sure. I mean, yes, I grew up in Hong Kong up till 11th grade, and then I came, to the United States and spent my senior year in boarding school, and I've been here since then in the country, and of course, I just went through the path of, because I've always known that I wanted to be a physician, and so I just went through the path of studying really hard, and attending medical school, residency, fellowship, and I think going to medicine is, of course, just really from the idea of wanting to help people, and I thought that was the most straightforward way to do it. My parents happen to be both physicians, and they're retired, but they never forced me into medicine. And in fact, my other siblings are not in the medical field, and so I just chose this path, and I enjoyed that human connection with the kind of that long-term relationship that I have with patients, and so I chose hematology oncology because I think that really helping patients is beyond just addressing their diagnosis, medically, but also it's important to address their psychosocial well-being along with the families, because it's you're not in this alone, and we're in this journey together, and we all have to die at some point. That's a fact, and we don't know how or when. Sometimes, a lot of times actually, sometimes we have an estimation of when that's going to happen. And I think during that process, it's like, you want to live the best life that you can and preserve the quality of life that you can, and also really just have that as well-being as possible during a very difficult journey.
Beautiful. I mean, Susan understands better than me all these. You're in the front lines. Tell us a little bit. So, Susan, what do you think? What is you can understand this much better than me. In that, really, what is, how do you communicate with the patients and everything?
Yeah, I just, what's going through my mind is cancer, it seems so multifactorial, and we seem to have, the trajectory hasn't been going down, it's been going up with the numbers and the ages. And it seems like, really, I don't know anybody whose life hasn't been touched in one way or another, somewhere in your family, a family member with cancer who's made it through the battle, who didn't make it through the battle. But Dr. Mary, something I read really stood out to me, and you said that systems aren't designed for loss. And I'm thinking, how is it possible in 2026 that our systems aren't designed for loss, when you so eloquently said we are all going to die, and for some reason we don't quite prepare, and it's always a scramble at the end?
Yeah, I
How is it
think
that our systems are not prepared?
I think somehow there's this idea that you know w- we're going to continue to live forever, kind of like that idea, even though in the back of our mind that oh, we're going to leave this world. But I think some, maybe partly denial or ignoring or avoiding that subject, and so I think that partly it's when someone gets cancer, um, there's always patients will ask, why me? And it is a valid question, and but at the same time, it's like, you may be feeling that, oh, it shouldn't be happening to me, but then it's like, why not? And so I think, the idea of that, um something bad shouldn't happen to me. I think that's kind of like the basis of, hey, loss or negative, shouldn't be happening in life. But at the same time, is I think part of dealing with the cancer journey is to kind of accept things that happen that is out of our control, and whatever we can control, it's like, how do we approach the situation, how do we work as a team, and how do we kind of make the best out of it. I think that's kind of the, um, sometimes it's a challenge, and sometimes it's really a beautiful thing that we can craft to make a very bad situation into a more neutral, or more tolerable thing for both the patients and the families.
You
Oh,
said that so well, a beautiful thing that we can craft. I love that you just said that, because it is possible. I mean, I've been at the bedside with, acute loss, and then, a chronic something that's been longer, and people don't know, but it can be done. It can be done. Death can be done with honor, with integrity, with, it can be a positive experience if we craft it beautifully. I really appreciate that you said that.
More than a when you do that, more than that is a families involved. How do you, somebody has a cancer, suppose, how do you communicate with that? Is there any techniques there, or you go straight to tell the truth and walk away? It's a very emotional subject. How do you communicate that process?
Yeah, so I think in my situation, kind of my everyday is that a lot of times is the patients already come with a diagnosis. It's
Yeah.
because they're already diagnosed, so they come. But then I still have to, unfortunately, I guess, deliver some bad news in the sense that sometimes they don't realize how advanced it is, and because they sometimes, for example, they know that, all right, I have cancer in the breast, and then there's also cancer in the liver, and they're like, all right. And then when you mention the word stage 4 cancer, and they're like, what, I have stage 4? So it's sometimes it's like that term, even though we're just dealing with the same thing, it has a whole new meaning for the patient,
Mhm.
that they're like, am I going to die? That's kind of like the very next question. And I think it is best that, when I see patients for the first time, or when we have to talk about the first time about their diagnosis, or have to break that news, it's best to have at least one other family member with them, because a lot of times it's really a ton of information that I am sharing, and I'm also mindful to kind of take a pause in the middle, just to let them say, hey, let me pause here, do you have any questions? And I think that sometimes when you have another person there, then they're kind of like the more clear-minded person. The patient themselves may be sometimes overwhelmed, or denial, or anxious, all you name it. And I think just to, and it's important to really read the room, to see what the atmosphere is like. Sometimes you can sense the tense, the and the tense atmosphere, even when you're just walking into the exam room. And and I think, just as I'm sharing the information with the patients, you kind of like do your best to read the unspoken language, to see what's going on. Are you going too fast? Are they kind of like confused what you're saying? So I think that's part of the thing is, besides just like, not a good idea to just say the diagnosis and leave the room. And I think it's important. Like, I I think one of
She's
the
cutting off a little bit. Yeah, she needs to rejoin. Yeah.
Well, I hope she. There
Yeah,
we go.
I think we have a little
right,
bit of a, yeah.
it's okay.
Yeah,
So
Things
it's
happen.
fine.
yeah,
It happens.
Dr. Mary,
Yeah.
sometimes as a nurse, no, when I'm with patients who are at different stages of cancer, and I've been in the room many times, both in emergent and in a longer term type settings, where I guess I struggle with the fact when I know what's happening and you know what's happening, and no matter how many times you've explained it, they still have a longer time on earth in mind. I'm trying to figure out how to nicely say, how do you deal with patients that aren't getting it, and or the hope when family has so much hope, but we know what we're looking at. This person does not have long to live. And how
Mhm.
do you deal with that? How do you deal with, do you have that conversation, or do you let it be their death? Do you let it be their family's way of going about it, and read the room like you just said, and kind of give them what they need for their death situation?
I think there are a lot of ways to approach it. It depends on, the family dynamics also. It's like some people want to know everything. So you know, I just tell them as is. I think I'm honest about it, but I can I think I can be nice and firm about things, and so sometimes I'll just say it's a pretty popular question to ask. So how long do you think I have? And I would say that, well, I'm not God. I don't know for sure, but if I have to best estimate or guesstimate, it may be 6 months or less, or 3 months, depending on the situation. And I always say that, I wish I am wrong. It could be longer. It could sometimes be shorter. And with treatment, if you're responding to treatment, it may be longer, and things can always change because cancers, they don't read the textbook, they don't follow the rules, and that's why they're cancers. So I leave it as, somewhat neutral, but at the same time is that kind of like see how they, how they accept my answer and go further or just stop right there.
Yeah.
Yeah, one if somebody says that, like, my don't tell my mother she has a cancer, and the children come and ask you, what do you do with that situation? How do
That's a
you
good question.
wh-
Happens all the time, Romana.
yeah.
Yeah. Yes. So that is also a very popular thing that happens. I would say that it
Unfortunately popular, yeah.
yes, it doesn't happen. I guess I would just say it's more so in the inpatient setting when patients are sicker. And I always would tell, it's usually the children that would say that, usually. It's like, don't tell my mom, I don't think that she can handle it. A lot of times it's very interesting. It's actually the patients themselves, a lot of times they kind of know something is wrong and they can sense this in their body. So they can probably take it better than the kids can take it. And I'll just, especially when the patients have a sound mind, it's a different story. If they're demented or, have some other medical issues that they don't understand, then it's not very helpful to explain the situation. But if they have a sound mind, I would just say that, well, it is your parent or the patient's disease, and the patient has a right to know. So I can ask that, do you want to know what's going on, with your body, or what the findings are? Do you want to know everything? If the patient says that, well, I don't want to know everything, or I'll you know what, just talk to my daughter about it, then I may just avoid it, and not, and just respect the patient that way. But a lot of times is the patient will say that, I want to know, and I'll just say, you know what, this, you're an adult and you have a sound mind. I'm going to respect you because you're the patient, and I know, the children, they want to protect, and not, have the patient get hurt, but that's probably not the best way, because sometimes really knowing is half the battle, we always say. And have that, diagnosis, like, if, especially if they're feeling something is not right and they don't have a good explanation of it, that itself causes, stress in the body.
Mhm.
It's like, what is going on? And sometimes it's like, of course you don't want that cancer diagnosis, but at least if you know it, all right, that's what's causing me to feel this way. And then you can decide, am I going to do something about it? Like, some people may say that, I'm too old, I don't want to do anything, that's it. And some people may be like, hey, you know what, I want to do something about it. So, and then I can, just approach from that point.
So, Dr. Mir, your list of difficult conversations is kind of a thick stack in your line of work. So we kind of let me write, if we're in a acute care setting, they're not feeling well, these are the types of conversations you're having. We know the next conversation, or one of the ones, if they are sick and they're maybe towards the further end of their disease state, the whole resuscitation conversation. It's interesting to me, the kind of, it's a taboo conversation. It has to be had. Who has it? You have it. Do you have it with the patient? Do you have it with the patient's family? It's a very difficult conversation. Can you shed some light maybe to our audience about what that conversation is for and how you approach it?
Yeah, I mean, I think I always look back and say that, oh, maybe sometimes I can have this conversation a little bit sooner. I'll just say that usually, when patients, even though they have stage 4 or advanced cancer, if they're doing fairly decently, it's not so much avoiding the conversation for me. I think it's more like we're focusing on the quality of life and like the treatment or the disease control, with systemic therapy. But when I see that the patient is declining, and I never want to wait till the last minute to bring up the conversation. And I would, so when I see that the patient is not responding to treatment, or really just clinically the performance status, overall it's not doing well, then I bring it up. I would say, all right, it's kind of get to the point that, or maybe, we need to focus instead of focusing on treating using aggressive therapy on the patient, is maybe the focus now, it's more appropriately to be comfort. And then, so I kind of start with that, and also kind of a lot of times we'll link into the conversation about, since this is the situation, and we know what where the direction is going. So I just want to know, if not to say that it's going to happen anytime soon, but if if there's a situation where you stop breathing or your heart stops, what would you want to do? Do you want to have, say, a ton of people rushing in to kind of do the CPR, chest compressions, and put a tube down your throat, that type of situation? Or, do you think that, all right, this is your time, and we'll just make everything comfortable and not have that traumatic experience? So I kind of like would just bring it up that, and a lot of times patients will be like, I don't want to be resuscitated, because I know, this is a terminal illness. And I think it's just good to bring it up earlier, that we know that, all right, so this patient is do not resuscitate. So in case anything happens, or end up in the hospital in whatever situation, then we know that, all right, if it's, really cancer related, no. Of course, if we're still treating the patient, like say if it's an acute infection, we're still going to treat the patient. It's just when the heart stops, or or you stop breathing, that's kind of the point that we do something different.
Yeah, thank you.
Let me ask you a question on the other side of the story. You and Susan, both you receiving end. You see people dying. On particularly you're a cancer specialist, and you see a lot of people dying in hospices and everywhere. How do they stress? The doctors. We are not aliens. We are all human beings, right? The emotions and all this come with it. How do you handle that? How do the people, the healthcare professionals, handle that? That's always mystery to me, even though I know lots of them. How do they handle that patients dying on them?
All right. So I think it is that, of course, I feel the feelings. I'm a human being, and I think that it's very important to allow ourselves to feel the feelings. It is okay to feel sad. It is okay to be upset about things, about patients. And I think that it is also important to to have some grace for ourselves. It's that, all right, I think, especially earlier in my career, like if someone died and I know that they were going to die, and I would think that I did something wrong, even though I didn't. And I think it's very important to catch that, and remind ourselves that, well, you know what, we did it by the guidelines. We follow, everything that we can, with some modification, because every person is different. And we did the best that we could, and things just going to happen. And I think, just being nice, talking to ourselves nicely is a very important thing, and also allowing ourselves to just feel upset and just process that emotion. It's like, I'm upset because I didn't expect the patient to die so quickly, and that's okay to just, feel it, and be like, you can also reflect that, all right, what could you have done differently? Probably not, and I think that sometimes you were like, oh, I should have, could have, but you don't have that, the 2020 hindsight, right? During the real time situation. So I think that, yes, we do feel the feelings. We're nice, being nice to ourselves is very important. And I think that just at the same time, it's like not making it super personal, in the sense that, like, not bringing it up to be, oh, it's my responsibility for someone else's well-being. I mean, yes, it is, but at the same time, is that I did the best that I can, and then the outcome is like something that we cannot fully control. And I think that's a very important thing, especially for me as the oncologist. As you mentioned, I deal with the death and dying a lot of times. I mean, thankfully now these days is a lot of times people are just coming back for regular follow-ups and they're doing well, and maybe even cancer-free. But yes, and I do have to talk about cancer progression. We have that death and dying, discussions on a regular basis, and I think that it can be heavy on on our emotional, I guess, capacity to handle things sometimes. And I think the other thing that is very important is that we have to be, we have to take care of ourselves first, because if we have a good, decent emotional fuel or reserve, then it is also, we have a better capacity to handle the negative situations and emotions.
Yep. Real well said. Romana, you said one of the words that fits into this space quite well, hospice. So a couple of the different options that cancer patients and end-of-life patients have in general is palliative care and hospice. And unfortunately, hospice has a bad rap to families who are uncertain or unsure, because when they say the word hospice, hospice means they're dying. This is it. This is the end. And hospice might be one of the greatest things ever since sliced bread, as far as it comes to patient care and caring for not only the patient so well, but the family. Do you find that people, when they hear the word hospice, that it causes a whole family to kind of fall out?
Great question.
Yeah, actually, almost as a lot of times it's like what you said. It's
Mm.
oh, am I dying?
Mhm.
That's kind of like the usually the initial reaction. So I always clarify that. Well, not not right now. And it's and I always say that we as in oncologists, a lot of times we actually um, are referring patients kind of late to hospice, because whoever qualifies and to go to hospice is like when we estimate the life expectancy to be 6 months or less. And the thing is it doesn't have to be cancer patients. It can be advanced COPD, cardiac, non-cancer situation. And I also explain to patients that, well, sometimes, like, things can change, in a good way, that if you live beyond the 6 months period, sometimes, like the hospice team will reevaluate the situation, and they may extend it, or sometimes, occasionally people get kicked out, of hospice in a good way. So I think, just really just to clarify that it is, hospice is, yes, there's that criteria of the 6 months or less life expectancy, but really the focus, we want the hospice care, which, again, I think a lot of hospice facilities and teams are really doing a great job, is it's really for symptom relief and the quality of life. It's like, you want to minimize the pain, or if someone have trouble breathing, you want to make sure that they're as comfortable as possible. So I think, I always talk to the patients about those things, and I think that give them a better understanding of what hospice is.
Y- Yeah, I wanted to ask you, this is a question I have for you, is a personal question. Is that if there is one of your colleagues, stuck with a cancer or some other major illness, how do you take that is compared to the patients? Is it different that you approach the doctor, colleague, different than, nurses that you work with, or doctor work with, professionals having that episode? How do you deal with that kind of situation?
I think that's a good question. I guess personally, I haven't had that, like a close colleague, I would say. I mean, I've treated, you know, doctors or doctors' families, but not like the super close situation. I think I do my best to be, to maintain the professionalism, and sometimes it's like, of course, if I know the person better, we may communicate a little bit more, in terms of, sometimes it may be after hours. I mean, I try not to do that, and set, nice and firm boundaries, because I can be a good doctor and not be available 24/7, and that's okay. And to preserve my well-being, right? Because if I'm not well, I can't offer my best to my patients. And I think, to answer your question, is, I think, no matter who it is, I just do my best to take care of the patients. And I think that that is my approach in general. And that, I always believe that even though I'm running behind a lot of times, and I have enough time to be present, to see the patient and listen to what they or their family have to share, and especially their concerns, and to address them. So I think that's kind of my general approach.
Well, like you said, Dr. Mary, the doctor does get to go home. We want you to go home. We want you to sleep and spend time with your family, and have meals, and exercise, and smell the fresh air, so to speak. So you do a lot of work in this space, and you one day said, "Hey, guess what? Under this umbrella of self, I'm not just a doctor, right? There's lots of. I feel like doctors get stuck in that I'm a doctor, and that's their whole self. And I feel like you've spent some time helping doctors figuring out there's a lot more parts to that self than just that pure doctor space that's not supposed to be 24/7. Can you ever
Beautiful.
go home?
Great.
Yeah. So I think that's a very important thing, because, what about maybe 40% of physicians reported some degree of burnout. And the thing is like, I think that used to be me too, several years ago. And I was just really carrying work home, charting at nights, weekends, and really, doing work, hours more, a lot more hours than I signed up for a regular full-time job. And that wasn't living. I was just barely surviving, and that was not good for patient care, because I didn't really connect with the patients the way that I wanted to, because I was just too drained and exhausted. So I think, and of course, the kind of the, time management and charting efficiency was my biggest problem. And now that I have managed that, I'm going home consistently, by 5 o'clock, even though I'm seeing the same, number of patients, like about what, 25 or so patients a day. And I think because of that, I have that, um, mental and physical capacity to hold on to more, because I am not just surviving, I'm thriving. And I have free time to do things, as you mentioned, Susan, that I can enjoy, hang out with my family, with my friends on the weekends, and do things that I enjoy, like even like walk in the park, things like that. So I think, that's why I want to help other physicians do the same, because if they can reclaim the time, they can reclaim their energy, their well-being, and they can serve better, in taking care of the patients.
So when I come back, I will ask you questions on your tagline is I love that always. Stress is optional. You say that all the times. That's a very beautiful thing. But I'm a physicist. One thing I say, if you ask me, your time is up. That's the only thing I say. We don't have a. So I'm going to present a topic, and time is up. As a time, how the physicists look at the time, and how the biology or the medical people, medicine should take that time concept. Can you, Nabia? Can you bring that presentation, and then yeah. So this bring them in the side. Yeah. This is my favorite topic. In fact, it is I wanted to address the time concept. Medicine needs a kind of richer concept of time. The reason is that my father in India, what happened was there was a lot of unemployment during his work, during his days, and then they retired all the people at the age of 55. And he thought that in India is a cultural thing. Time is okay. He's already old, and he's retired, and then at the age he's still vibrant. He can work, but the retirement made him. Everybody thinks he's old, and that psychological effect is there. In fact, time is we all misunderstand that time is in aging. Is not aging, is not the time. We need to really understand the biology. That is a big mistake we do. Time somehow we connect with the aging. That is definitely not a right way to do it. But let me explain to the in the maybe Mary knows more than I do about this. Aging in cultural lenses is very different. In Japan, Kiro no Hi is the elders they respect. The elders' day is a national holiday in 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 Japan. In India also they respect elders. That is changing, unfortunately. But the USA, aging means you got health problems. That's what they think. It's just a mindset. See that how different mindset they have. So in Japan, elders are respect for elders is a national holiday. I was surprised to know about that. So where age is the question. It's a lot of people in just in a way, people make a comments that is too old for surgery, or is high risk for age. These are all the age should not, you can use the age, but age should not be the answer. Age cannot be the answer. That is not the way the medicine should work. Already doctors know about that, but still, in a colloquial language, we people use a slang as a age as a factor for all the things. So age is widely used, but poorly precise. Same age and different. One person ICU with a struggling, other person is in Mount Everest. Think about that. The two people at the same birthday, sharing same birthday, has entirely different biology. So the calendar doesn't work. All on the clock is very different for both of them. That is the time factor. That is the one thing that I love. So calendar age is a very different than a biological age. Sometimes it depends on the. I don't have to tell, both of them are in the medical field. 65 years old feel like 50. So that is a calendar age, is because of the body and cognitive, body and mind, how functional they are. It is all depends on those things. Actually, we can measure that. Calendar age counts years, biological age reflects life. That is more important in medicine. We need to shift that thinking. Actually, that's what my goal is. The time should not be. Biology follows change, not the calendar. Time is, medicine already works on the change. Already doctors work on those kind of things. They know they find out the biological age, or they know the process to find out. So I think, a lot of times biology is much more uh, not transparent. It's a complex system. Biology is a complex system. Is a time is no, you cannot attach the clock to that. That is a attaching clock or calendar is, as we just Mary was saying. I'm not God. I don't know when is time is up for you. So it is a lot of differences in biology, right? That I don't have to tell all these people. They know everything. The inflammation and the oxidative stress and the cellular repair method. How well you can repair your own cells, or injury for broken bones, for example. You can fix it. So that is how fast and recover, that kind of thing. Recovery is very important. So that is the that is the age time that you think. Aging is accumulated change. It is not as a trajectory, not the birthday calendar. Is not a calendar. Is a trajectory of the cellular degradation. That is the aging actually. So let me. So aging is accumulated change. Inflammation, damage, and loss of reserve. These are all aging is a trajectory, not a timestamp. So that make sure that we understand the time. The clock should not be attached to the biological process. So what the we already doctors already do this. There's a biological age. They know how to measure the frailty index. Gait speed. For example, if you have 1 meter per second, if you are less than 1 meter per second, high risk patient. C-reactive protein CRP they measure for inflammation, and the albumin is a reserve protein. How much you can take the information and all those things. How can you react to the another thing we do. I used to sell this machine, autonomic function test. I can tell in a parasympathetic system response to the problems. You can measure the parasympathetic response is very important. It also tells you how well you are biologically, how responsive you are. And then grip strength, it's very strange, I didn't know this. Grip strength can tell you how it can tell you mortality and the high risk patients. In fact, that's a very is a lot of studies are done on it. I was surprised. And function daily shows, they can get up and then cooking and changing, go to the bathroom and change clothes. That all the functionality is very important. That is different. That determines the biological age, not the some clock on the wall, or not calendar on the wall. So that is the biological age is very important. The real clock, if you wanted to put a clock in the biology, that's one place you can put there. When the reversal is not possible, so suppose somebody is a broken bone, you can fix it and they can be. I broke my hand one time. I'm normal now. So that is a reversing. That is the clock comes in when the reversal is not possible. That is the way the clock really comes in. That's a one-way progression to the neurodegenerative diseases, fibrosis. All of them are one way. Is a time is a one-way flowing there. That's where the clock comes in, but not reversal. Reversibility is very important. Think about that. The real clock is loss of reversibility. You cannot repair it back. You cannot back to the previous system. you know that is a that is in physics. We learn quite a bit about that the entropy is actually a prohibitive factor for us. So these are all the previous system reversing. In biology some extent is possible. That means once you lost that reversibility, the clock comes in. That's So we have to shift the model. It's not a time-based medicine; it's a state-based medicine. Function, trajectory, and reversibility. Reversibility is very important. Trajectory, the how fast that is going, as is depends on the genetic factors and environmental factors, so many other things, and the function. All of them are we need to shift the model a little bit, thinking in the direction of nowadays, particularly living longer. People are longevity is in the center of talk now. So we need to shift the model, thinking about the time based medicine is not the right one. State based medicine is the new way of thinking. But these are the same people with a different context. Astronauts. I interviewed one astronaut actually, Shana Pandya from Canada. The people who go to the moon or any other, even in space, is a rapid loss of muscle and bone loss. Is a very rapid. Then isolation. I don't know whether you saw the Brad Pitt movie. That is Brad Pitt's movie is the Astrada. Is a cognitive decline in the when you are by yourself. Cognitive decline in the space is very very real. That's where neurofeedback was invented. In fact, so that is the loss of that's a the in the space. The people in the microgravity environment, people lose a lot of things. That is they lose health and both body and mental health. It is a very progressive way it moves. Then athletes can reverse it back. They are very in a good shape. They can train. They are in a adoptive mode. They can adoption is very good for the athletes. If you go to the sick patient in the ICU, it's a problem, right? That's a entirely different organ stress and frailty. All of them are play. So is a context is important for the aging rather than just putting the calendar there. That is, every physics, even physics shows that time. I tell you how the physics think about time. You'll be surprised. I'm going to explain to you. Even let me before the physics. I'm going to talk about Hindu gods. Even the time is different for Hindu gods. You know that. Human in the human god, the Hindu gods. We have a different kind of gods. We have a lot of 300. We have 300,000 gods. So some gods have these 365 Devas year, the angel, in the middle, is a 1 year for them is 365 human years. When Brahma is ultimate God, is a 1 day, 1 year of Brahma is a 3.1 trillion. This is Carl Sagan in his Cosmos talked about it. So it's a cultural dependency as a mythological religious. The time varies with the culture, with a religion. All these things is the perception of time is very different in that sense. So, but how the physics think about it, let me tell you what the physics think about it. Medicine needs a new, richer concept of time. Classical time is in the Newtonian mechanics, in the regular world. You see, clock is fixed. It's ticking forward. The clock is always moving in a regular intervals. Disease progression, for example, you can do that, is a linear progression. That is where the linearity comes. That's a classical time. That is in the classical time, Newtonian time. That is Einstein time is very different. Einstein said that if you see interstellar movie, that if you go to the black hole, near the black hole, every hour is a 7 years in the earth, human years. So that actually goes back, and McConaughey, he goes back to see his own daughter. She's older than him when he went back to see her. So Einstein time is very is a variation in the context. So it is a very different is a biological age, is a functional system. We need to apply that idea of Einstein time into biology. Biology is a complex system. It is a frailty index and all those functional aspects involved. It is a variable. Is a context based. Quantum time is a very interesting. Quantum time is a quantum physics based on the time is fixed in the background. Even though time is fixed, everything is else is probabilistic. Everything is undeterministic. And so energy, position, momentum of a particle, all of them are probabilistic. We don't know where they can be. Energy can be in three places. Same electron can be in three different places. Once you observe, it takes one of the places. The same thing, energy also could be multiple places. Multiple energy levels. Zeeman effect, it is called. So when you observe, it takes one of them. So this is a classical, these quantum physics things. So if you think about energy, position, all of them are probabilistic in the quantum world. So how do you apply into the medicine? The disease is a complex mechanism. Biology is a complex system. We think, if as a physicist, we think it's a complex system. It is a unknown. Its outcomes are unknown sometimes. Uncertainty in the outcomes. Dr. Marilyn was saying that, this I'm not God. I don't know what that outcome is going to be. So that is absolutely possible in the quantum time tells us this the nature embedded in the nature, this the uncertainty. So what I would say, so now we are on the crossroads of aging. Is not a one way, may not be one way. We are learning about a lot more things about longevity, and I know very little about it. But I'm following David Sinclair and all those people. They're trying to reverse Benjamin Button. Going backwards. It's possible or not, we know. Thank you for watching. Let me bring my guests a little bit about the time I talked about physics. you know. Thank you. Yeah. So, how, I like your tagline, stress is optional. It's a beautiful, even though it's simple, but it's a powerful thing behind the message, behind it, right? Powerful message behind that. Tell us a little bit, expand on that one, stress, why it's creation of our mind, all the stress is, right?
Yeah, well, I think it's the feeling of stress is really comes from how we think about things, in a certain situation. Like, say, I think for a lot of physicians, for example, it is easy to feel stress when you're thinking that, oh, there's too much to do, or there's no time, since we're talking about time. um, and that can be very stressful. Even just saying that sentence, like, there is no time, or I have no time, it's kind of easy to make you tense up. So the when I do believe that stress is optional, because it's like, in the same situation, like, say, I have 15 patients left, and like 10 phone calls, and nurses are calling me for different things, and I can just, instead of thinking that there are too many things to do, I can think of it as, all right, there are these things to do, and I can handle it one by one. And that immediately, I'm already, calmer than the previous version of me. And then, when I'm calmer, I can think clearly, and make decisions, better decisions, and just do things one at a time. So it's like, it's important to really realize, when you're stressed, is like, go back a step to say, why am I stressed? What am I thinking that's causing me stress? Because stress doesn't come out of nowhere, and it's not the situation itself that caused you to feel stress. Is because of your opinion about the situation.
Opinion.
That Yes. So that means that if you think of it differently, you're going to generate a different emotion.
Mm.
So I think sometimes it's just really letting ourselves to entertain and be open about, the other possibilities,
You,
to say that, to generate another emotion.
Yeah,
you
and
get,
truly, you had on one of your slides that you went past fairly quickly, Ramana. You said time is observer dependent.
Mhm.
And in Dr. Mary's example you just gave, you could be observing that I have 15 more patients and I'm behind and all these things, or you could take a breath and observe just what you just described. Observe, you know what, I've got this one at a time. It just, where you put your focus grows. So we have to be very intentional about what we are observing.
You told us a little bit of mantra, very powerful mantra you gave me. Is that, don't never say, one of the things I hate to, I teach my children, don't say, I don't have time. I don't have time for this, dad. And they say that, for example, I have a good friend here, he's a cardiologist, he's a very busy practice. And then on the top of it, he runs a political organization and a cultural organization. He's very active in all the, and community extremely. I never heard he saying, I don't have time. I never heard that he's saying anytime. He act like he's available to everybody all the times. That's a way of managing it. The mindset is also powerful that people feel comfortable with it, with that kind of a attitude towards people. So that I don't have time is a wrong way of thinking, and you're absolutely right about that. Yeah. So tell us a little bit about that. What do you, as a if you're stressed out, you said that the way our opinion about the stress is causing the stress rather than, that most of the time that is absolutely true. So tell us a little bit about that. How do you solve that problem?
So in terms of feeling stress, is, I think, have the awareness of, of course, recognize that you're feeling stressed, and really, as I mentioned earlier, to go back and figure out why you're feeling stressed, and then, and just really be open to figure out, you know other ways to look at the situation, because, when you have a more neutral mind, you come up with better ideas of how to tackle the actual situation. So just going back to me, like, having all these patients, and maybe charts to write and other things to do, it's that, all right, and I think Susan said it, to kind of, like, be that observer of yourself too, and just look at yourself without judgment, and say, all right, this is the situation, and I can handle this one at a time, and I'll just prioritize things. I'm going to get things done. And I think Romana, as you said, it's the I have no time. That is not true, because everyone is given 24 hours a day. And some people, they can run like 15 businesses, right? Like, not to say that you have to do everything yourself, right? You leverage your team, you do things, to manage it. I think, in medicine also, especially, I think in oncology, like for me, it's okay not to do everything yourself. Like, I don't have to make every single phone call myself. If it's something simple, you leverage your team, your nurses, your medical assistants, your front desk staff, whatever it is. So it's like and then when I have to sit down to have this, difficult conversation with patient about their cancer progression or the death and dying situation, I take the time. Doesn't mean that I'll be there all day long, but I always tell myself that I am going to take the time to take good care of the patients. And if I'm running behind, it's okay, and I'll just catch up. Like, sometimes some other patients, they're just more straightforward, so I don't need to spend that whole 15 minutes or whatever is scheduled, so I can quote unquote steal some time from there. And I think that, yeah, time, I think, for both the physicians and the patients and the family, it's really, it's it's important thing, because yes, once time is gone, we can't go back. It's not like Back to the Future that we can go back to take it back. So I think that for physicians, it's important to know the time management to be efficient, because then you have really more time and capacity to take care of patients. And of course, patients, it's like they want more time on this earth, to do the things that they want. So we wanted to make it a meaningful time, during their disease process. So I think, yeah, time is a very fascinating entity.
And thank you so much, Dr. Leung. You're always giving a new insights into it. I like your tagline, "Stress is optional." I'm going to take to that to the world, of learning from. Thank you so much for joining with us. It's a truly an honor. Can you hang on for hang on here after the podcast? I want to talk with you, and if you, I want to introduce somebody. Just a couple of minutes after the podcast is going
Sure.
to be over. Yeah, thank you so much. It's a honor and privilege to have you. You shed a new light on the patient journey, physician journey, and oncologist life every day, facing the death and life and death. You're the best testament for that. Thank you so much.
And thank you,
Thank you
Dr.
very
Mary,
much.
for the time and the attention that you give your patients and that you've given us here this evening. When you finally do sit in the room with those patients, the focus from you to them, that is a gift. And I'm certain that regardless of your 15, 20, 25 patients, that when you do get in that room, you give them that gift of your attention. And I thank you for that. It makes a
Thank
big
you. Hang on,
Thank
hang on there, Dr. Leung, in 1 second. I
thank
want to
you.